Good morning, doctor. We can hear you.
Okay. I'm very sorry, we had a technical problem with the logging in, so that's caused us a delay. So I hope we start straight if everybody is online.
Yes, doctor.
We have two lectures to go through, so I will be a bit fast because we are already late. Our first lecture is on strabismus, which is also called squint. Yeah. Strabismus refers to the deviation of the eyes. And we know very well that when a child is born, they are born with the potential to see, but they are not born seeing. And this potential needs to be developed through stimulation of vision. Any factor which interferes with this process, for example, strabismus, cataract, or ptosis, eventually results in permanent visual reduction, a condition called amblyopia. Our lectures will aim at addressing the following issues: the causes of strabismus, the types or classification of strabismus, the common assessments for strabismus, and management of strabismus. The causes of strabismus are diverse, but for this case, we are going to divide them into two broad categories. That is the sensory causes, that is the processes, anything which interferes with the processing of vision, that is through refraction within the eyeball and focusing light onto the retina. And so this will include refractive errors, any partial opacities of the cornea, any opacity of the lens, which are partial, not complete, and retinal abnormalities, for example, retinoblastoma and other retinal tumors, even retinal detachment. Sorry, I think yes, stop moving. Then the motor causes of strabismus will include the cranial nerve pulses, for example, cranial nerve 3, 4, and 6. Conditions like myasthenia gravis, trauma, and congenital abnormalities of the muscles. That's what we see in congenital squints, and also in diseases of the orbit, which cause restriction of eyeball movements, like in thyroid eye disease, orbital tumors, and orbital inflammations, orbital cellulitis. We classify strabismus under two methods. The first one is according to the direction of deviation of the eye, whether the eye is deviated inwards, that is towards the nose, that is called an esodeviation, or it is deviated outwards from the nose, that's what we call an exodeviation. And then whether the deviation is downwards, which is called hypodeviation, or upwards, that is hyperdeviation. So those are the four directions an eye can take in terms of deviations. So as you can see from this diagram, the left eye is deviated inwards. And so that is an esodeviation. From this diagram, the right eye is deviated outwards. So that is an exodeviation. Sorry, I jumped some. The second method of classifying strabismus is based on the manifestation of the deviation. In most cases, that's what we are talking about here, we are talking about an eye which is obviously deviated. An eye which is already obviously deviated. And that is what we call atropia. Or we also have a deviation which is hidden, but when provoked, you can then see the deviation of the eye. And those are what we call the phorias. But for this discussion, we are going to first focus mainly on the obviously manifested deviation of the eye, which is called tropia. And therefore, based on our earlier classification, which is ESO, exo, hypo, and hyper deviations, we can then completely describe strabismus as an esotropia, exotropia, hypotropia, or a hypertropia. So those are the complete description of a deviated eye. Esotropia, that is either esotropia, exotropia, hypotropia, and hypertropia. So this is an exotropia, as we have described earlier. I'm sorry. Okay. So that's what I've just been talking about. So when you combine the two methods of classification, then we can, in terms of tropias, then we have an esotropia, exotropia, and hypertropia, as I've just said. We need to look briefly at the anatomy and physiology of extraocular muscles as we did with the strabismus, because the movement of the eye is a function of the extraocular muscles and its innervations. So I would like you to revise the anatomy of extraocular muscles, their origins, their insertions, and their innervations. I'd also like you to revise the physiology of extraocular muscles, that is their actions. Most of these muscles, except the lateral rectus and medial rectus, which has got mainly one function, that is the adduction for medial rectus and abduction for lateral rectus. The other extraocular muscles have got more than one functions. For example, the superior rectus is an elevator, but also it is also an abductor. The inferior oblique causes depression and abduction and extorsion movement of the eyeball. Yes. While the superior rectus causes elevation, adduction, and intorsional eyeball movements. So they have more than one function. So I wish I would like you to look at all those muscle by muscle so that you can know the functions of each of the extraocular muscles. We talk about the assessments of patients with squints. The assessment for any patient with squints include taking history. The history should include the time of onset, the circumstances surrounding the onset, for example, illnesses, trauma. There are any complaint of if they have double vision, because if the two eyes are not coordinated, then you start seeing two images of the same object. So whether they have double vision, and what makes it worse, is it when they look towards the right, when they look towards the left, or when they look upwards? And also if they have changes in the position of the head, do they have head tilts? So those are important history to take. And when we are assessing for patients with the strabismus, we also do physical ocular examinations. And as I told you earlier, I said if the strabismus onset is right from birth, then it may interfere with the normal vision development, which will result into what we call amblyopia. And so we need to assess whether vision is affected if somebody has got a long-standing strabismus. So visual acuity is important. We need to assess for ocular motility to find out if there's any one muscle or more than one muscle which are paralyzed, so causing the strabismus. We also do the cover test. That is, you cover one eye, and then you can look at the effects on the fellow eye. So when you cover the right eye, if the eyes are looking straight ahead, you should not see any movement in the left eye. But if the left eye is deviated, the moment you cover the right eye, you see the left eye moving to take fixation. So that shows that the left eye was deviated before the right eye was covered. So cover test is important. We can also do prism cover test. So you cover one eye, then you put a prism in front of the fellow eye, and then you keep on varying the power of the prism until you see the fellow eye becoming straight. That is, come to the center of the eye. Then that is a very accurate measurement of the deviation of the eye, and you can measure it in terms of prism diopters. We have seen that one of the main causes of strabismus, actually in children, the commonest cause of squinting eyes is actually refractive errors. And so any patient presenting with strabismus must have refraction done. And then you also need to look inside the eye. I've already told you earlier that some of the causes of strabismus include partial cataracts, partial corneal scars. So you use the microscope to examine the eye to see whether there is any scar on the cornea, whether there is a cataract on the lens. And of course, you also have to do fundoscopy. I said one of the causes is the retinoblastoma. So, or detachment. So you have to do fundoscopy to examine the fundus and rule out that there is no retinoblastoma or any retinal detachment. The management of strabismus takes basically three main components. If a patient is a child who is less than 8 years and has already developed amblyopia, you first correct the amblyopia. And that the treatment for amblyopia is actually by patching or occluding the fellow good eye. So if I have my right eye, which is squinting, and has already developed amblyopia, what I will do is I will patch the left eye so that I force the right eye to begin seeing. And that is visual stimulation for the right eye. So that is what the treatment for amblyopia. So you first treat amblyopia before you do anything. And then if the patient also has refractive error, then you first correct the refractive error and then you do the patching. So it is very important that you first correct the refractive error before you even patch for amblyopia. So correct refractive error, you put the glasses on, then you begin patching the fellow good eye. And then finally, if all those ones don't correct the squinting eye, then the final management is surgery. And the principle of strabismus surgery is that you have at the back of your mind that one muscle is stronger than the other one. So if supposing it is an esodiviation or an esotropia, you know that the middle rectus of that eye is stronger than the lateral rectus. That's why the eye is the middle rectus and the weak muscle is the lateral rectus. And so the principle of the surgery is that you weaken the strong muscle. You weaken the strong muscle, and then you strengthen the weak muscle. And there are so many procedures of weakening a muscle and strengthening a muscle. For example, one of the procedures for strengthening a muscle is resection. So you get a muscle, supposing that is the lateral rectus, which is weak in esotropia. You want to strengthen the lateral rectus, you resect it. That means that you remove part of the lateral rectus and make it shorter. And in the process of making it shorter, you have increased the strength of the muscle, because the muscle is like an elastic tissue. And so it can pull, it can stretch and relax. So if you resect it and pull it back to the same position, it is now shorter but tense. And so it has more tone to pull the eye into that direction. So that is a strengthening procedure, resection. But you can also do a weakening procedure, which is the recession. So you disinsert a muscle from where it was attached previously and pull the insertion posteriorly, that is backward, so that the muscle is now less tense, and so it becomes more relaxed, and so there's not much tone in it. So in children, when we do this surgery, it is both to straighten the eye and improve the development of binocular vision. That is, the two eyes are seeing one image at the same time. But in adults, most time now we cannot cause the development of binocular vision. So when we do strabismus surgery in adults, we normally do it for the purpose of cosmesis, that is to improve the look or the beauty of the face. And those are the purpose of. So we don't stop, we do strabismus surgery in adults, much as not to improve vision, but we only do it mainly to improve the cosmesis of the face. So that brings us to the end of our first lecture, unless we have any question, so that we prepare for our second lecture. Any question?
Yes, Doctor, I have a question.
Yes, please.
So my first question is regarding the correcting refractive error first, and then we deal with the amblyopia. I'm imagining that the refractive error cannot be corrected unless the specs. I'm imagining that the refractive error
Yes.
cannot be corrected unless the specs are on fully. Or is it different that when someone puts on specs for a certain period of time, then their refractive error is corrected, and then
Yes.
you can do the correction of the amblyopia?
Mm-hmm.
Is it like that?
The issue here is that, you know, for a child who has got refractive error, their vision is blurred, they don't see clearly. And therefore, your purpose is to first get the spectacle on so that they can begin seeing clearly. And then now, after that, you then patch the other eye so that that eye is forced to be seeing, so that you stimulate visual development. So that is the purpose.
How much time before?
Oh, the time for patching, I didn't talk about amblyopia. The management of amblyopia is that the amblyopia onset is very high when the child is very fainting or the eye is covered with something. They can develop amblyopia even within 1 week. And also their recovery is also very fast. So when you patch for just 1 week, they also recover. So on average, according to the time frame, we said we patch the eye for 1 week per year of life. What does that mean? That means that if you are 1 year old, we patch your eye for 1 week. That is for 7 days consecutively. If you are 2 years old, we patch your eyes for 2 weeks. So that's the formula saying 1 week per year of life. So that is the duration. So a child who is 6 years should be patched for 6 weeks. So it is just a rough guide. Sometimes you need to be assessing the eye. If the vision has recovered in 3 weeks, you don't need to go for the whole 6 weeks. But guide is that is the duration you should take. Yes. So the duration depends on the age of the patient. We don't manage amblyopia in adults because adults, once you have developed amblyopia, it is not reversible after 6 years. So we don't need to waste your time patching an adult who is more than, or anybody who is more than 6 years, because the vision has already developed. And so if they have amblyopia, it is permanent. They cannot be reversed.
Then from the time we give them the specs to the time we patch the eye, how much?
No, the patching should begin immediately the specs is on.
Okay.
So the moment you have now got the spectacles, you should begin the patching. You don't need to wait again. That they should put a spectacle for some time. The moment they have the spectacles on, you start the patching.
That was my question. Thank you.
Thank you very much. So if there are no other questions, can we move to the next? Somebody wants to ask a question. Robert.
Yes, doctor. Good morning.
Good morning.
What exactly is patching?
What? Patching.
What exactly is patching?
To patch, to occlude, to cover. So you cover one eye completely so that it doesn't see. The purpose is that you want to force the eye which is squinting to start seeing, because the two eyes actually are rivals. They compete for visual space. And so if you have the two eyes working at the same time and the other one is weaker, the stronger one will predominate, and so the weaker one will keep on being suppressed. So if you want the weaker eye to also develop vision, then you cover the strong eye which is seeing clearly, so that the weaker eye is forced to start seeing, and in the process of doing that, it will develop vision. So the word patching is covering or occluding, whatever way you want.
Thank you.
Okay. So we are moving to our next lecture, which should be fast too. refractive errors. Okay, so if we are all on, our next discussion is on refractive errors, which is also called Hypermetropia. For those who know some bit of optics, we know that the eye is an optical instrument or an optical organ whose try to focus it onto the sensitive part of the eye, which is the retina. And so if you have a problem with that refractive process of the eye, then you'll start getting problem with your vision. Your vision will be blurred, just as we have been talking in screen, our strabismus. So light can either be, for a normal eye, the light rays are supposed to be refracted and they should fall onto the retina. That is a normal eye. And that's what we call emmetropia. But if the light rays are not being focused onto the retina, that is, they can either focus in front of the retina or focus behind the retina, which is virtually, then that state of the eye is called a refractive error or an emmetropia. So that is what our discussion is all about. Okay. So I've just said refractive errors refer to the state of an eye which is at rest. I'll come again to talk about what I mean by an eye at rest, where parallel rays of light cannot be brought into focus onto the retina. An eye which is at rest is an eye which is relaxed, because as you know, there are muscles inside the eye. The mechanism for you to see far, to see a far.
Okay.
Doctor,
Okay?
everything we are still seeing your screen.
Okay, fine.
We are here really seeing your screen.
Okay, fine. Okay, let's proceed. So I'm just trying to explain what I mean by an eye at rest. That's an eye where the ciliary muscles are relaxed. And that's what we mean an eye at rest. And that is when you're looking at a distance. When you're looking at a near object or you're looking at a near surface, your eye is accommodating, so it is not at rest. And refractive errors is actually one of the leading causes of visual impairment. Actually, it's the first cause of visual impairment globally, affecting very many people. And of course, also is a cause of blindness in a number of people. So refractive errors remains a big public health issue. So our aim for this lecture is to describe the types of refractive errors and then the causes of refractive errors. We also need to look at the clinical presentations of refractive errors and the management, the common management of refractive errors. So what is refraction? I believe we know that very well. The bending of light rays when they pass through a medium is what we refer to as refraction. So when light travels from one medium, which is less dense to a denser medium, it is always bent. Or when it is traveling from a dense to a less dense medium, they are also bent. So the bending depends on the differences in the refractive index of the medium where they are traveling. So the refractive components of the eye are mainly two. The first one is the cornea, which is the first and the most important refractive surface of the eye. The overall refractive power of the eye on average is about 60 diopters, and the cornea contributes approximately 40 diopters of the refraction. Then the other refractive surface of the eye is the crystalline lens, and the crystalline lens contribute approximately of the lens is higher. The power of the lens becomes higher when you are accommodating. So the power of the lens is not fixed. We said on average it is 20, but it may go the power of the lens because the size of the lens changes as it accommodates. Yeah. But the actual length, because it has changed, but it may grow in children. The actual length changes slightly as they grow, what we call the myopic shift. But at a certain age, the growth of the eyeball stops, normally around the age of 20 to 25 years. So that's why refractive errors normally stable also stops. So I already told you about hyoeropia. That is the normal refraction of the eye. That's when the light rays are focused onto the retina. That is what we call hyoeropia. While ametropia is a refractive error, match between the actual length and refractive power, and parallel rays don't fall on the retina. There are types of refractive errors. There's nearsightedness, which is myopia. There's a farsightedness, which is hypermetropia. And there's astigmatism, where the light rays in the different meridian are all not brought into one focus on the retina. We shall look at that later. And then presbyopia, which is the problem of accommodation. So those are the types of refractive errors. There are 4 types. Now let us talk about myopia. Myopia is a refractive error where an eye which is at rest, the parallel rays of light are not brought into focus in front or anterior to the retina. And there are causes or some associations with myopia. Some of them are purely genetic factors, where I think people are born with abnormal big eyes. So those are genetical components. So that's why you find that myopia may run in families, because there's some genetic components. The other cause, of course, is the size of the eyeball, which is what we call the actual myopia. The eyeball is bigger than normal. And then the others, or sometimes the refractive power of the eye is higher than the normal refractive power of the eye, probably due to curvature. So when the corneal curvature increases, for example, there's a condition in young children, adolescents, when the cornea becomes more thinner at the center, and therefore it forms what we call, something like a cone, and that increases the actual length of the eye, and also the curvature of the cornea increases, increasing the refractive power of the cornea. That's what we call keratoconus. So those are the key main causes of myopia. That is the size, actual length, and then there's a genetic component, and of course the curvature. The symptoms of myopia, the children with the myopia normally don't, or any patient with myopia, they don't complain of eye strain, because the muscle is at rest. That's for distant vision. Their main complaint is that they don't see far. So they have problem with seeing distant image. Yes. For example, a teacher complains the child prefer to sit near the board because they are not seeing very well, and many others. Sometimes they may also squint. So they try to squeeze the eye and squint it so that they try to see better in the distance. And eventually, if they are children, they may develop amblyopia. So when you see a patient with myopia and you examine them, they normally have a very deep anterior chamber because the size of the eyeball is actually bigger than normal. And the ciliary muscles may atrophy, not dystrophy, but atrophy of the ciliary muscle because of too much rest. And in the long term, the vitreous may collapse, and there will also be changes in the fundus, what we call, if the myopia is very high, more than 7 diopters of myopia, there will be atrophy of the retinal pigment epithelium and thinning of the posterior pole. So you see what we call a tigroid fundus. It looks like the skin of a tiger. They are dark point and they are hypopigmented places. So what we call a tigroid fundus. Those are all features of atrophy of the retina, mainly of degeneration of retinal pigment epithelium. In the long run, the retina may develop a tear or a hole. Eventually, they get retinal detachment. Myopia usually increases with age. That's what I said. The eyeball keeps on growing. So as the eyeball keeps on growing in size, as you grow, myopia also keeps on changing. Yeah, so eventually it increases because if the power of the eye remains the same, but the size of the eyeball keeps on increasing, then the amount of the myopia also keep on increasing until up to a certain point. A myopic person can still see some objects clearly so long as they are near. And those are just calculations. We can also have pseudomyopia, which is due to accommodation spasm. So when you over accommodate and the ciliary muscle goes into spasm, they are not true myopia, but they are just spasm or so you can only see near objects because you are accommodating at the strong contraction of the ciliary muscle. So I already talked about the pathological causes of myopia, which include keratoconus, which I've mentioned earlier. That is, the cornea keeps on thinning at the center and becomes more conical. And so that increases its curvature. But also cataract also worsen myopia, because cataract also blur your vision and you cannot see far. So you may also appear as if you have myopia. Also, patients with diabetes mellitus, because the diabetes, there's high concentration of glucose in the blood, and that is also, it lead to high concentration of glucose in the cornea and in the lens, which increases their refractive indices, and so they become very highly myopic. So those are pathological causes of myopia within the eye. The treatment of myopia involves an assessment, which you first have to take a visual acuity to know that the patient has got a low visual acuity. And then when you use a pinhole, the vision of the patient should improve with the pinhole. For those who know some optics about the pinhole camera, is that when you reduce the size of the aperture of the hole which is transmitting the light, the clarity of the vision improves, because you are removed. If you have a refraction on a spherical surface, a sphere is not not like a part of a circle, because the radius of curvature of a sphere varies from the center to the periphery. So light, if light rays are passing through a sphere, they are not all brought at the same focus. Those who are near the principal axis, that's at the center, are brought to one focus, while those ones at the periphery are also brought to another focus. So that's what we call peripheral aberrations when light rays are being refracted through a spherical surface. So what the pinhole will do is that it reduces the size and so cuts off most of the peripheral rays of light, and so leaving only light rays near the principal axis to be transmitted and to be focused. And in this case, they will all be focused at one point, and therefore the image is distinct and clear. So that is what the role of the pinhole is. So if you have a refractive error and you bring a pinhole, your vision automatically will improve. And so that is one of the preliminary tests you do when you are assessing a patient for refractive error. So low distant vision, visual acuity, which improves with a pinhole. And then now, if that is the case, then you know somebody has got a refractive error. You now go through the process of determining the refractive errors. And this process of determining refractive errors is done through what we call refraction. There are two stages in refraction. The first stage in refraction is what we call an objective refraction. For those who are already rotating in the clinic, they have been to the refraction stage, and they have seen what is done in objective refraction. You can do what we call retinoscopy, or you can do an automated refraction. So all of them are within this clinic. So when you come here, take interest to see how they determine refraction by using retinoscope, and how they do refraction using an automated, or what we call an autorefractor. So that one determines objective refraction of the eye. That is what the state of the refraction of the eye is. But in life, you may not need that objective kind of refraction. There is subjectivity. Some people want to see very clearly, some people don't want to see very clearly. So you can now do what we call the subjective refraction, which is now you want to tailor the refraction according to the need of the patient. So that is what we call a subjective refraction. So those are the two steps in refraction. Objective refraction, either using retinoscope or an autorefractor to determine the state of the refraction of the eye. Then the second one is subjective refraction, where you now tailor the refraction to the need of the patient. So if the power was supposed to be -5, the patient may prefer to say, I want -4.5, or I want -5.5. So you adjust slightly to the need of the patient. That's what we call it, subjective refraction. And then eventually, after doing that, you can then give the prescription, which is that is now what the patient should wear, so that the refractive error is corrected. You can use a concave lens, which is a minus lens for myopia, or you can use a plus lens for those who have got hypermetropia. So for myopia, we use a concave lens to correct that. Money. Okay, tell them I'm just giving a lecture. Sorry, I have some visitors, so we shall finish first before I continue. So we say the treatment. We are already finished with that. So I was going to hypermetropia. This hypermetropia is an eye while at rest, where parallel rays of light from distant objects are brought into focus behind the retina. And the causes, as we have looked earlier, they can also be actual causes where the size of the eyeball is small. It can also be problem with the curvature or the power of refraction of the eye. Yes. And hypermetropia, as we know, it is normal actually in children, because the power of the eye in children are almost the same, but the size of the eye is small. So almost every child is actually hypermetropic, and that is the truth. So when you do refraction in children and you find a power of +2, there is no need to correct, because that is a normal refractive state of the eye in children. And of course, we can also get hypermetropia when the lens changes. So the main symptoms for patient with hypermetropia, which is higher than 3 diopters, they have visual impairment too. They also complain of eye strain, because they need to to use a lot of their ciliary muscle, straining them. And they may also get redness of the eye and watering. The redness of the eye comes because the ciliary muscles have got are supplied by the long ciliary arteries, long posterior ciliary arteries, and the anastomose with the branches of anterior ciliary arteries, which travels with the extraocular muscles. So when there is a spasm of the ciliary muscle to contract to focus on the near object, then they also compress on these arteries within the muscles, and the congestion of these vessels appear outside as reddening of the eye. That's why the eyes are red, and they also get tearing. Earlier, that children can also have squint because of the refractive errors. So these people always have blurred near vision. and they have issues with reading fine prints. And the blurred vision is more noticeable if the person is tired. And what we call asthenopia is asthenopia just refer to eye strain, which appears in form of headache, frontal headache, and burning sensation in the eye. That's what we call asthenopia. Then, of course, we call them accommodation hyoeropia. And of course, if the hypermetropia is very high, they also develop amblyopia. The other pathological causes of hypermetropia include when an eye has got the natural lens which has been dislocated. Sometimes you find the natural lens is displaced into the vitreous following blunt trauma, or even sometimes, so there's no natural lens. That eye become very highly hypermetropic. Sometimes after surgery, when we do cataract surgery and we find it difficult to put a natural lens inside the eye, we also develop hypermetropia. And then when you get retinal detachment, because when the retina is detached, the retina moves nearer to the lens. And so the distance between the cornea and the retina becomes shorter. And so sometimes you get hypermetropia when you get retinal detachment, and also tumors of the choroid. So those are some of the causes of hypermetropia. The treatment of hypermetropia, of course, I said you go through refraction, first visual acuity, pinhole, refraction, and this time we use convex lens. Now with the advent of refractive surgery, there are people who don't put lens anymore. We can just only manipulate the surface of the cornea. So we use lasers to manipulate the surface of the cornea, and we change the shape of the cornea, and we can correct refractive error. So we can use refractive surgery, or we use convex lens, which can be spectacles, or it can even be contact lenses. So there are so many things. There are people who can even use intraocular lenses to increase or to change the power of refraction of the eye by just adding another lens on top of your natural lens. Yes. Astigmatism refers to an eye which is when at rest, where parallel rays from different meridian are brought into different foci. So when you look at basically we can look at two meridian, the horizontal and the vertical meridian. You find that one of the meridian, depending on the curvature of the lens or of the cornea, if the curvature of the lens and the cornea are different in the horizontal or the vertical, then the light rays passing through those two meridians will not be brought into one focus. And so the etiology are almost the same. Most of them are hereditary, and some of them are because of the shape of the cornea, for example, or the lens. For example, for the cornea, some of them are acquired following, say, cataract surgery. As you make the incision on the cornea, you deform the cornea in the vertical meridian, and so you are going to induce astigmatism, and many others. Also, pathological ones, like you see them in keratoconus and so on. We have three different types of astigmatism. One of them is the regular or simple astigmatism, where the power and orientation of principal meridians are constant. So normally, and they are always in the 90, the angles are in a right angle. So the power astigmatism with the rule, which is there is astigmatism in the vertical meridian. And then there's astigmatism against the rule, where the angle is, where the astigmatism is on the horizontal meridian. So you can read about those ones because we don't have all the time. But there are also other astigmatism, which, so the simple astigmatism is one where one of the meridian rays is focused on the retina, while the other one is focused either in front or behind. That is a simple astigmatism. Whereas compound astigmatism, the two meridian, all of them are brought into different foci. One of them either in front, another one is behind, and then the mixed type. Then we have the irregular one, where the orientation of the meridian keeps on changing, so they are not fixed. So how do patients with the astigmatism present? They present like in hypermetropia with asthenopia, headache, eye strain, burning sensation. They also have blurred vision, and the images are distorted. For example, when you are seeing a ball, instead of seeing it as round, it looks or oblique. It looks like, I don't know which kind of ball, these balls which are not round. Yes. So that is how they appear. Something, if somebody is seeing a letter like A, they appear like N. They also tilt their head, and astigmatism in children can also lead to amblyopia. So the other as pathological cause of astigmatism is, say, in corneal surgery, corneal trauma, corneal infection, keratitis. Or sometimes when somebody has got a tumor of the eyelid. So tumors of the eyelid which can cause compress on the cornea and deforms the cornea. And also sometimes the lens. So those are some of the pathological causes. The treatment of astigmatism, the type of lens used in astigmatism is different from the other lens we have used for myopia and hypermetropia. In this case, the lens we use here has got power only in that angle or in that axis where there is a defect in refraction. So the lens is only made in such a way that the power of the lens is only grounded on that axis where there is defect. And so this kind of lens are called cylinders. So we use cylindrical lenses to correct astigmatism. And sometimes the same kind of lenses, we put them into contact lens, but we make the lens rigid so that it sits on the cornea and does not move and deforms the cornea. So those are different types of, but all of them have that the lens has power in that particular axis where there is a defect in refraction. So they are called cylindrical lenses. Finally, presbyopia. Presbyopia is a problem of accommodation. This time it is not a problem of distance vision. It is a problem of accommodation where there is a physiological loss of accommodation with aging. As you advance in age, you lose accommodation. And this process of losing accommodation with aging is purely due to loss in elasticity of the lens. The lens become more sclerosed, more hardened as you grow older. That is because the lens is made up of protein, and this protein or collagen, and this collagen can get denatured with time as you grow old, and they become more fibrous or sclerosed. And so they become more rigid and lose their elasticity. So that is the mechanism. So that presbyopia always affects people in the middle age from 40 years. So it starts at around the age of 40 years. And so from that time, you lose accommodation. So when you lose accommodation because of the fibrosis of the lens fibers, then that is what we refer to as accommodation. And so the near point, that is what you can't see things which are near. Normally we have the near point. The near point in an infant is about 7 centimeters, whereas in a normal adolescent is about 20, and then when you go up to 20, 30 years, about 25 centimeters. But as you grow older at 40 years, the near point almost goes beyond 40 centimeters, goes up to 50 centimeters. So the near point keeps on receding with age because of that loss of elasticity of the lens. So their complaints are normally failure to perform near tasks. For example, they can't read well, they can't cut their fingernails, and many others. When you have somebody who is 40 years and above complaining of problem with near vision, you know they have presbyopia. And so the treatment is like anybody with a long-sightedness. So you treat them with convex lens so that they can focus on near object. And as a rule of the thumb, we always say you lose 1 diopter of accommodation when you reach 40 years on average. And for every subsequent addition of 5 years in your 5 diopters. And so, for example, if somebody is 55 years, then they will need plus 2.5 diopter of correction for presbyopia. So these are some of the questions which can help you to revise. So what are the causes or common causes of refractive errors? And what is the most worried complication of refractive errors in children? And what do you understand by the terms objective and subjective refractions? And what types of correction can the patient with refractive errors get? Thank you. Any question?
Yes, thank you, Doctor. My question is in relation to astigmatism, how different for regular in the treatment we talked about regular astigmatism, how different are the cylindrical lenses from the other common lenses that are
How?
used? How different are the cylindrical lenses from the convex or convex or concave lenses which are used? How different are they?
The other, yes, thank you. The other lenses we are talking about, we call them spheres. The spherical lens is that the power of the lens is uniformly distributed across the whole surface of the lens. That's what we call spherical lenses, which can be spherical minus, spherical plus. That is spherical concave, spherical convex. This, when we say a lens is spherical, it means that it has its power globally distributed across all its surface, as opposed to cylindrical lenses where the power is only located in the direction or in the axis where the refraction is defective. So it is only located in that meridian. So the power is not globally distributed all over the lens. It is only confined to that area where there is deficiency in refraction. So that's why they're called cylinders. Yes.
Thank you so much, Doctor. Also, I have a question.
Yes,
Is there a role of using this light, this glare from phones and laptops have an effect on refractive errors? Then also, I didn't quite understand the first myopia, where I thought the problem would be on focusing the light from like near objects onto the retina, which is hard for the eyeball because they cannot constrict the muscles.
Let me first start with yes, the use of phones and so on. Yes, there is evidence that these phones worsen, or maybe they also cause refractive errors, and because of the brightness of light and so on, but yet to be proven scientifically. But what we know is that some of the lights from these phones, they cause a lot of glare, and because of glare when you have a scattering of light from an object. And so when an object is too bright and or it is scattering light, then it gives you a glare, and that glare affects your vision definitely. And yes, so it is there. And so what we do sometimes with this kind of visual distortion because of glares of light, we use spectacles where the lenses are colored, so that there's coloring of the light of the spectacle, so that the light is not so bright to your eye to remove the glare. So we call them anti-glares in green as colors within the lenses of the spectacle. Yes, so that is there are also special spectacles for those kind of circumstances where probably you may not be having true refractive error, but you have distorted images due to of light from the surfaces you are seeing. So we give you anti-glare into the lenses, yes, and we put some coloration, yeah, like chromatic coloration within the spectacle we give you. So some people just wear a spectacle without any power, but just only color in them to reduce the glares and the distortion of light. The second question was the myopia. Can you repeat the second question? You are talking about myopia something.
Yes, I'm wondering. Hello? Because, yes, doctor. Can you hear me, doctor?
Yes. What was the second question? I'm here.
Yes, my second question was that the problem with myopia with short-sightedness, I thought it would be problem with focusing near objects, not focusing distant objects, because the muscles can't constrict and focus the near objects, so they have problem with seeing near things.
No.
Okay.
No, myopia, which is No. Myopia, you have problem, you cannot see far. That's why we call you short-sightedness. You can see near, but you don't see far. That's what myopia refers. It is hypermetropia, where you can see far, but you can't see near. So myopia refers to problem with distance vision. You cannot see far objects clearly. That is what myopia refers to. It is not, it is the other way around actually. So it is hypermetropia where you have problem with seeing near, but you see far very well. So that is the difference. Any question?
Thank you, Doctor. There's some questions in the chat. I can read them for you.
Maybe very fast because I have a meeting to go through. Yeah, you read them very fast so that I can answer them.
Okay, Doctor, thank you. Sebabi is asking how safe and effective and available is a refractive lasectomy. Richard is wondering why the refractive index of cornea is 1.33 and that of the lens is 1.38 to 1.34, but we keep saying that the cornea has a more refractive power. Then the last question.
Can I first answer? No, can I first answer that one?
Yes.
Let me first answer maybe the first with two.
Yeah, the last one.
Let me start. Yeah, let me first keep wait for the rest. I said for the cornea, actually the cornea is not only one refractive surface, and the refractive index of the cornea is 1.33, but the cornea has got two surfaces. On top of the cornea, there is a tear film in front of the cornea. So we have light rays traveling from air, first get refracted between air and water and the tear film. That is the first refractive surface of the cornea. Then now there is a refraction between the tear film and the cornea. So there are two refractive surfaces on the cornea. That's why it has a very high refractive power. So it is not just one refractive surface, despite its low refractive index, but there is a refraction between air and the tear film, which is 1 and 1 point something. Then there is a refraction between the tear film and the cornea. So those are two refractive surfaces on the cornea. That's why it has a very high refractive power than the lens. The lens has a refraction of 1.38, but the lens is big. The aqueous got a refractive power between the aqueous humor and the lens is actually less. So that's why the refractive power of the lens is actually lower than the one on the cornea. I hope I've answered that. The first question was about clear up lensectomy. Sometimes they are very highly hypermetropic. And so removing the natural lens, that's what we call lensectomy, will restore them to normal vision, to normal refractive power of the eye. So depending, so when you determine the fact, we do all those assessments. We do what we call biometry.